All right, so ischemic strokes. So ischemic strokes are usually dark gray on our CT scan. Can't really appreciate it here as much. We'll point out the dark gray ischemia. Here's like a graphical representation. It is really, really darker gray than the rest of the gray matter, right? You have gray matter, white matter in the brain, and you have really, really dark gray compared to the regular gray. That's a area of ischemia. And that takes about 12 to 18 hours to develop. So if someone comes into that and they say, "Oh, this just happened 4 hours ago," you're like, "Lies! I know that's not a 4-hour-old ischemia." Okay, and if you take them to MRI, you can see within minutes. But we're talking about CT scan. Okay, so ischemic stroke is a sudden blockage, right? As we talked about, a clot fragment or a clot formation, right? Formation being our atheromas, a fragment being like AFib, right? And we have decreased cerebral blood flow, for instance, like stenosis or low blood pressure. All these things are causing ischemia to an area of the brain, right? We have our ischemic core. It's going to be dead in about 4 hours, right? So you have 4 hours to open that guy back up to maybe get some recovery. The sooner the better, right? That's why we say the be fast score, to get people to the hospital as soon as possible so we can get them treated if possible, if need to be. And we have the area around it, which is at risk. That's the area where we want to maintain euoxia and euglycemia and euthermia, and we want to make sure we reduce metabolic rate. We want to make sure we are avoiding secondary injury, right? That was the whole idea behind ICP, right? Because we have a decrease in cerebral blood flow because of an occlusion of some sort, right? Then we are going to have low O2 and glucose. Low O2 and glucose leads to cerebral edema. And how that happen? Well, we have decreased ATP. We can't keep stuff out, right? Can't keep calcium out. Calcium influxes, glutamate gets released. We got our Six Flags guy is coming back, and he's going to start activating everything, right? And you can get seizure activity after that. You get necrosis and apoptosis buttons get activated as well. Okay, so we want to avoid this brain edema, which can cause hyperperfusion. It's a whole spiral to global death and global death of neurons, right? So that's the idea behind making sure the oxygen is adequate, and we want to make sure the blood flow is good. Our brain's going to say, "Hey, I got low blood flow right here. I'm going to crank up the blood pressure to 11." And literally, your patient can come in with a blood pressure like 210 systolic. They're going to be trying to get perfusion past this obstruction that's here, right? They're trying to raise the blood pressure enough to squeeze past the ischemia. They're also trying to get blood flow. They might not be able to get to this area right here. It's like, oh, stuck. I got a blockage right there. I'm going to go around the long way, right? I'm going to take the 405 down Ventura Boulevard, but cut across to get back over to the 5 on the other side, right? Have you ever been to LA? You know what I'm talking about? Anyways, so that's you're gonna try to, you're not gonna go 100 miles per hour, 210 miles per hour, but you are gonna get there eventually, right? And of course, the traffic stalls all the way. You're gonna miss your improv show at Melrose, right? So you got to be able to get all the way across. So you got to make sure you have adequate speed or adequate flow through the brain, right? And this is why I was talking about the watershed infarct. So basically, this area of the brain can get, if your blood pressure gets too low, you dial down the blood pressure too fast, you're gonna expand that area of ischemia. So your body is going to automatically auto-regulate, and it's going to compensate by raising the blood pressure when you have ischemic strokes, right? When you have hemorrhagic strokes, they're going to do the same thing. It's like, I'm not getting blood supply. I'm going to raise the blood pressure. You're like, cool it, cowboy. You're going to make yourself worse, right? But ischemic strokes, there's a lot of finickiness about changing blood pressures, right? It's like, do I do 220 over 120? Do I 180 over 110? Do I 185 over 110? Do I do 140 to 160? Now, do I do down to 120? Right? So there's all kinds of different ways to play with the blood pressure, which we'll talk about. And we've talked about it with IV titrations and with hypertension. We'll touch base on it again because it does get confusing. All right. So like I mentioned, we have about 4.5 hours for that clot to settle. And by settle, I mean it becomes cross-linked, so that the clot is just like a little clot out to dry, and then eventually your body's going to start cross-linking it so that it is super, super firm, and it's not going to go anywhere, right? And it's going to be part of the vessel, or it's going to be part of the surroundings, right? And that takes about 4.5 hours, right? So after 4.5 hours, your clot is irreversible, and the tissue is now infarcted. Infarcted technically means dead, but we've had medical advances where infarcted means just ischemic, right? So I can work on this. I can make it better. Or I can flip that house. These are different things that we can identify, right? And we identify it by knowing the last known time well, right? When was the last time they were well? And maybe we can bust the clot with thrombolytics. Okay. The ischemic tissue, like I mentioned, is your penumbra. That's the area that we are trying to restore blood flow blood flow to, and we're trying to make sure no more inflammation happens, no more edema happens. We're trying to improve cerebral blood flow, avoid cerebral edema, right? Improve oxygenation, make sure the glucose doesn't get bad. We're trying to fix this, right? And ischemic CVAs, if they can't fix that, all the cells start breaking down and breaking down. Fluid starts rushing in, and it starts, separating blood vessels. And you can even get a hemorrhagic conversion of an ischemic stroke. So ischemic stroke can turn into hemorrhagic strokes, especially if they're big. Okay, so that's the idea behind our ischemic strokes and what's going on with them, right? Hemorrhagic strokes are very, very similar, right? They have a lack of blood supply, you get cerebral edema, and you get your blood pressure can start to go up to try to fix it, but that can, that can falter. Okay, so moving on to vessel territories. So the territories of your brain, you got your left side and your right side. You've seen some all cool images about left side and right side. Does it help us clinically too much? Not really. Maybe as an outpatient, maybe it's like, oh, you're not good at math anymore, are you? But it's not something you're going to assess on your NIH stroke scale. It's like, okay, lift your right arm, 10 seconds. All right, what's 4 times 12? It's like, that's not going to be on the NIH stroke scale. And it's not something you're going to be assessing readily in a neuro patient in a hospital. But it's outpatient. Yeah, we can see. Oh, you were an artist before. You lost your right. You got absent flow to your right side of your brain. You might lose that artistic ability, right? You lost it to the left side, right? Left side's for math and writing. They can't write good, right? Language, right? So L for language. L for one more letter up is M for math, right? So the reading and comprehension, right? Or learning, right? These are things that can get a deficit of when you have a stroke to your left side circulation, right? A left MCA stroke or a right MCA stroke, they're going to feed either side, right? Here's my right side over here, my left side over there, right? If I'm in SAP, they're both going to have the same deficits as far as motor deficits and sensory deficits. I'm going to lose my arm on my right if I have a left side MCA. I'm going to lose my arm on my left if I have a right side MCA. But then we have the more, not finicky, but more long-term deficits like math and learning or artistry, right? So those are our left-sided CVAs versus our right-sided CVAs. We're feeding our blood supply up into the circle of Willis right there, and we feed the left and the right side of our brains, and they will feed different territories of our brains, right? Yes, left and right, but then you would think like it'd be designed where the MCA feeds the temporal lobe only, or the occipital lobe is only fed by the posterior circulation, or the anterior circulation only feeds the frontal lobe, right? We would think that would be cool, but that's not how it works, right? It's really territories. So like our MCA, our middle cerebral artery feeds this portion. A little bit of temporal lobe activity over here, right? A little bit of parietal lobe activity right there, right? And the anterior circulation, or the ACA, or the anterior cerebral artery, feeds the frontal lobe portions a little bit, right? If you cut the brain in half, you look inside, we're actually feeding a big portion of the middle portions of the brain, right? So you're going to see deficits in those areas. Right, so you're going to see some combinations, little mix and match, like temporal lobe activity. Yes, you're going to have some language problems when you have an MCA stroke. You're also going to see some parietal sensory problems and motor problems with the MCA. The frontal lobe is responsible for what? What does your frontal lobe do? Yeah, decision making is what separates you from an ape, right? When someone steals your lunch in the break room, right? You don't go to them and slash the tires and poison their husband, right? It's like that you went too far, right? So that's what separates you between murdering somebody versus not murdering somebody, the frontal lobe. And occipital lobe, that's for vision, right? So when we talk about PCA strokes, they feed the posterior circulation back in the back there. So you're going to have some vision problems. And also we mentioned, the vision doesn't make a straight shot from the eyeballs to the occipital lobe. It takes a stop where? At the temporal lobe. So guess what? MCA strokes, you're going to have some vision problems as well. Okay? So the artery systems, or the arterial system of the brain, it overlaps on the lobes. It's not, vessel for vessel or vessel for lobe, right? So obviously if you block the vessel further down, you're going to have more destruction compared to a little tiny little branch out in the periphery, right? A larger vessel will be a lot more symptoms. We talked about laterality a lot in normal neuro assessments where you have ipsilateral and contralateral, right? Things decussate at the level of the medulla, and cranial nerves don't, except for number 4, but they all are going to have these symptoms, which we're going to talk about. Okay, and of course you're going to lose function of certain lobes, so you're going to see those symptoms kind of be mixed and matched elsewhere. I'll point those out as we talk about each vessel. Okay, so our lobes and our functions, just again, our frontal lobe is more for emotional response to something. Our executive functions, how we respond, our emotional intelligence, right? You ever talk to someone who's like, man, they were rude, or man, why they took that news wrong, or I was just trying to tell them how to park their car, and they like slashed my tires when I went inside, right? That's not having good emotional intelligence, right? Or not good in be able to manage your emotions, right? So the homunculus, though, makes a scary return again. This is what's laid across these lobes right here. If you remember the previous slide, the MCA doesn't go all the way. It only goes about that far, right? So it's only going to affect a portion of the homunculus. What portion is that? Well, it's this portion right there, right? So when you have an MCA stroke, you got face weakness, you got arm weakness, right? And I got some speech, because look what's also for speech, tongue. Right, so I got tongue dysarthria, I got some dysphagia, my tongue's gonna help me swallow too, and I have some facial drooping, and I have some arm weakness. And we know everything goes decussatory style. It's gonna go from one side, and it's gonna decussate across, right? It's gonna cross over at the level of the medulla over here, right? So that's a contralateral hemiplegia, or contralateral arm weakness, or contralateral arm loss of sensation, contralateral facial droop, okay? Compared to cranial nerves, which don't do that. Cranial nerves just go right across, right? Or they don't actually decussate. They are on their own tract. They go through little holes in the skull, right? Little foramina in your skull that you had to learn anatomy, all the different 27 different holes, right? So they all go through little holes and they go to their area. They don't cross over. That'd be ridiculous to learn. You would nobody pass anatomy in that case, okay? So yes, we have the different areas here. We have our MCA territory over here, right? There's our MCA territory. Okay, there we go. Or not. All right, so we have our MCA territory over here, right? And we have this middle territory in the middle here, right? So this middle territory, this little pie right here, that's actually fed by our anterior circulation, our ACA. And we'll point it out when we talk about the ACA, but you can see the ACA is going to have symptoms of foot weakness, right? Or the lower leg. And it's going to be the contralateral or ipsilateral side. Contralateral, because motor and sensory function always decussates, right? So that's laid out by the homunculus. That's the purpose of the homunculus, to kind of visualize what is being affected, right? And also they're going to have some incontinence, because the genitalia are fed by the ACA as well. All right, back to the MCA though. The MCA feeds the homunculus, but it also feeds the temporal lobe. And we said the temporal lobe is responsible for speech, right? We have the Broca's area, we have the Wernicke's area, or the Wernicke's if you're German, right? You have different areas that will be affected, right? Broca's area is responsible for making you have formed speech, whereas Wernicke's area is responsible for the word formation, right? If you can't find words, that's a Wernicke's area problem. If you can't articulate the words, that's a Broca's area problem. If you can't connect concepts, that's this articulate, what's it called? The arcuate fasciculus, what's it called? Yeah, arcuate fasciculus, which connects the two, right? You can form the word, but you can speak it, but you can't form the concept. That'd be like a word salad situation, right? And of course, we have different types of aphasias. There's ones that are global, where they can't speak and they can't understand. Or there's ones where they can't understand. That's a receptive. They're unable to receive information. Or there's an expressive aphasia, where they can't express themselves, right? And that's kind of where they have the Broca's aphasia or the Wernicke's aphasia. Okay, so we have different problems that can develop because we have an absence of function of our temporal lobe, which is fed by which vessel? The vessel that feeds our face, arms, and speech. That's our MCA, or our middle cerebral artery. Okay, so that's the idea behind our lobes and the overlap there might be with our different vessels.